Hello. Yeah, good afternoon. Yeah, good afternoon. Am I audible?
Yes, sir. You are audible, sir.
Okay, fine. I should just check. I am sharing the screen now.
Yes, sir. Your
Okay.
screen is visual, sir.
Huh?
Okay. Yes, sir. Your screen is visual.
Yeah, visual okay? Fine.
Okay, sir. Okay, sir. Everything fine.
You are from Three Dots?
खुदरा विक्रेताओं, होटलों, क्लबों और रेस्तरां को जारी किए गए लाइसेंस में नियमों की अनदेखी की गई है। विभाग
घुसना है, वो एंट्री गेट पर जद्दोजहद कर रहा है। पूरा प्लेटफॉर्म श्रद्धालुओं से भरा हुआ है, जहां से स्टेशन का भी वही
फिर तो सही।
Yeah, good afternoon to all. Is there anybody from Three Dots? Anybody from Three Dots?
नमकीन भी ले दो।
Yeah, good afternoon, Dr. Sanjeev.
Sudhir, good afternoon. Good afternoon.
I'm just looking
Yes.
for the moderator. Where is the moderator from Three Dots?
Dr. Tiwari has delegated his responsibility to me to moderate this today's session of yours.
Okay, that's fine, that's fine.
So, should I continue?
Yeah, sure.
Or should we wait for somebody else to join?
I think we can start.
Okay, that's nice.
Yeah.
Good afternoon, everybody. It's my proud privilege to introduce Dr. Sudhir Mehta, who is a member of Physicians Research Foundation, API, as well as Director Professor of National Institute of Medical Sciences, Jaipur. He is also retired head of department from SMS Medical College, Jaipur. He is a very good academician, researcher, and a learned teacher. His expertise in hematology is well known throughout the country. And I think he is a course director, he is a course director of this hematology short course, ICP short courses, which is a brainchild of Dr. Kamlesh Tiwari, who is Dean ICP and past President API India. Dr. Tiwari has delegated his responsibility to me to introduce the learned speaker of today's topic, which is XYZ of CBC. We all know that CBC is an integral part of any patient, either belonging to any specialty, and which is with the interpretation of CBC is very, very important. Dr. Sudhir Mehta will be focusing the light on the intricacies of CBC, which appears to be a very simple test, but it gives a lot of information. Over to you, Dr. Sudhir Mehta, please.
Thank you, Dr. Sanjeev Maheshwari, my dear friend, for your fine introduction. I'll just request all the attendees, please unmute yourself. So I can start my.
सर ये महीने भर बाद जैसे नॉर्मलाइज बंद हो जाएगी मेडिसिन?
No, I hope my screen is visible to everybody.
जो बैड कोलेस्ट्रॉल बोलते हैं
Sudhir, your screen is very well visible. I request all the participants, please mute their mic.
तो ये मान के चलो दवाई तो लेना पड़ेगा.
All the participants are humbly requested to please mute their mic so that learned speaker can start his topic.
So my dear friends, last Tuesday I had talked about
हाँ, खाने पीने में ध्यान रखो, ज्यादा तला भुना, ज्यादा ऑयली, ये सब चीजें नहीं खाना है.
Am I audible to everybody? Please mute your mic, please.
महीने भर का दवाई लिखता है मैंने भी.
I think Sanjeev, I'll start now.
Please.
Yeah. Good afternoon to all the attendees of this short course program in benign hematology. And last Tuesday, I had talked about the ABC of CBC. I had talked in essentially. I just moved the screen. I think the screen is not moving. Just let me do something. Yeah. Okay. So last Tuesday, I had talked about the ABC of CBC, and I talked about the CBC printout, which is available at the district and sub-district and even in rural areas. And we had talked about the red cell distribution width, and we had talked about the various types of histogram related to RBCs, WBCs, and platelets. But now, and this talk was very much relevant to even the physicians who are working in the rural areas. But now is the time for us to have an understanding of the complete CBC, which gives you a huge quantum of information regarding various hematological and even non-hematological diseases. And therefore, we have to think beyond the conventional CBC and differential of it. Yeah, this was the CBC report I had shared with you last Tuesday. Now, this is generated on the automated cell counter. Now, on the right side of the slide, you can see the RBC parameters, WBC parameters, the platelet parameters, and the reticulocyte parameters. And on the right, you have the histograms and the scatter plots. Today, I'll be talking on immature granulocyte percent and the number, IPF, that is immature platelet fraction. And then I'll talk about the immature reticulocyte fraction as well as red hemoglobin equivalent. These four important advanced hematological parameters, which is depicted on the CBC printout, gives you a huge information upon what is happening in the bone marrow. Now, time has come that for small diseases, we do not perform bone marrow aspiration or biopsy. Now the time has come that many of the information what we get from the bone marrow can be obtained from the peripheral blood. So today I'll be talking about these four advanced hematological parameters. Now, why they are important to us? Number one, they are automatically measured in the course of routine hematology testing. All you required is adding of certain software programs to the existing cell counters. And now generation of these parameters, they require minimal additional
Dr. Sudhir.
or reagents. And
Sudhir.
The lights are not working.
So
yes,
the slides are not moving.
it is moving on. Okay, let me do it. Is it moving now?
No, it is first slide is visible, only XYZ of CBC. Not thereafter.
Okay, let me am I audible?
You are very much audible. You are very much visible too, but the slides are not moving. Only first slide is visible, XYZ of CBC. Can you make a slideshow there? Probably thereafter it can work.
Yeah, I have done slideshow now.
But it is not there in the screen. Slideshow is not there.
Is it there?
No, not yet.
Not yet. Just wait for a moment. Can somebody help me out? Anybody expert from the IT person can help me out?
Now this is the next slide is there.
Okay, this is the slide is there.
But next slide is there, but it's not in slideshow mode.
I am doing
it is in editing mode.
No, this is the slide. Now, is it visible, the next slide too?
Second slide is visible, but this is not in slideshow mode. It is in editing mode.
No, I have done in slideshow only. It's there in the slideshow only.
Must be some technical issue. Can you go to the third slide so that we can see whether it is moving or not?
Yeah.
That's good. Third slide is there, but it's okay. Now you can proceed.
No, it is visible.
It is very much visible.
Yeah. Okay. So I talked about the CBC printout, and today I'll be focusing myself on these four advanced parameters which are generated on the cell counter. Is it now visible? Yes, Sanjeev.
Much visible, Sudhir. Carry on.
Okay. There was somebody was okay. So these are the four parameters probably which I will discuss, and these are generated routinely in the cell counter printout. And the most important feature of these four parameters are they're able to analyze the cell precursors. I told you that many of the hematopoiesis activities which are occurring in the bone marrow, initially in a few decades back, we used to perform bone marrow aspiration and biopsy in almost every patient who had abnormal CBC report. But now the time has come that we are able to visualize actually what is happening inside the bone marrow by looking at the peripheral blood parameters. And therefore, these parameters, they have a very important role as far as in guiding the treatment and management strategies. And they, the most importantly, they meet the key test criteria of clinical relevance, reliability. They can be obtained with very quick speed and affordability. Now, as far as the anemia management is concerned, we have these two parameters, reticulocyte hemoglobin content or equivalent and immature reticulocyte fraction. For thrombosis, we have a parameter which is immature platelet fraction, and for infection surveillance, this is the immature granulocyte count and fraction. Now, when we talk about the testing in iron deficiency anemia, these are the classical tests which we perform routinely. Now, these on the right side of my slide, you can see the enhanced anemia testing, which include the immature reticulocyte fraction, that is IRF, and reticulocyte hemoglobin equivalent or content. So coming to the first part of my lecture, now, do we have a parameter which can assess the erythropoiesis very early? We know erythropoiesis, we do not, till this parameter was available to us, we did not have any idea what is happening in the bone marrow as far as erythropoiesis is concerned. And that's why we used to perform bone marrow right and left. Now with this parameter, the most of the time, of course, we do not now perform bone marrow aspiration. And this is a very important, we should have an understanding of this parameter and what is the clinical utility of this parameter vis-a-vis the traditional reticulocyte count. So today, the first hematological parameter I'll be talking on is the immature reticulocyte fraction. It is the earliest reflector of erythropoiesis, what is happening to the erythropoietic series in the bone marrow. It indicates the least mature RBCs with high RNA content. These are also known as shift reticulocytes. Now, for sake of understanding, we have one peripheral reticulocytes and the reticulocytes which are there in the bone marrow. So they constitute the shift reticulocytes. Now, since it's a fraction, therefore it is a ratio of young immature reticulocytes to the total reticulocyte count. Now, it increases much before the total reticulocyte count. Now, whenever we treat any patient with nutritional anemia, the reticulocyte count increases towards around 2 to 5 days, toward the end of the week. But with this parameter, we can assess the erythropoietic activity within few hours, within 24 hours. And therefore, in clinical practice, this parameter has replaced the total reticulocyte count. Now, this parameter is available in large number of cell counters. All you need is to add a software related to the reticulocyte parameter. Now, the fluorescence flow cytometry, which are installed in these cell counters, they show 3 stages of reticulocyte. These are the low fluorescence, medium, and the high fluorescent reticulocytes. And IRF is simply a summation of what? Medium and the high fluorescent reticulocyte. In other words, they are the most immature form of reticulocytes. On this scattergram of the reticulocyte, what you can see, the RBCs is there. This is the reticulocytes, and this is the most immature reticulocytes, which constitutes immature reticulocyte fraction. Now, what are the indications of its use? It has widespread indications in the diagnosis of various hematological and non-hematological conditions. It is a basic diagnostic workup in various types of anemia. It helps in monitoring the effectiveness of treatment. It helps in monitoring the erythropoietin therapy in patients who have CKD or heart failure. It is also a useful marker to see whether the bone marrow generation has occurred following bone marrow transplantation or following chemotherapy or radiotherapy. This fraction also helps in identifying and verifying aplastic anemia. And last but not the least, this parameter we can use for the optimal collection of stem cells from the peripheral blood. Now, this fraction also helps us to decide upon the blood transfusion, that is the packed cell transfusion. Now, if a patient has low reticulocyte count and low IRF, it means there is very little erythropoietic activity in the bone marrow, and these are the patients who would require transfusion provided they are hemodynamically unstable. Contrary, if a patient has low reticulocyte count but high IRF, which means that the erythropoietic activity within the bone marrow is fast and is producing RBCs, and therefore, if patient is not hemodynamically unstable, then there is no need to transfuse these patients, because within few days, within few hours to days, the reticulocyte count, the TRBC count, hemoglobin would improve. Now, the reference range for this parameter ranges from the one manufacturer of the cell counter to another, but usually for females it is 1.1 to 15.9%, and for male it is 1.5 to 13.7. Now, just remember, the blood its stability is only in vitro is only 6 hours. So the blood sample which is collected for determination of IRF should be subjected to cell counter machine within 6 hours. Many times what happens that the blood is collected at night and next day it is subjected to the cell counter. But then if it exceeds 6 hours, the report of IRF would be not accurate one. Now, this parameter is available in large number of cell counters I have already told you. And these cell counters are installed in the medical college hospitals and big corporate hospitals in cities and even at the district level. But they are not reported by the pathologists because what I have told you in my last class, only certain numerical numbers, numerical parameters are typed and you get a typed report. Only a few numerical parameters are typed and rest of the parameters which are very important to the clinicians is missed unless until you get a CBC printout. So to summarize about the immature reticulocyte fraction, it is the earliest indicator of erythropoiesis. It gives you the actual rate of erythropoiesis which is occurring in the bone marrow. And therefore, the reticulocyte, the traditional corrected reticulocyte count and reticulocyte production index, all we have abandoned because now simply this parameter gives you the actual rate of production of the RBCs. And its usefulness has been documented in various hematological diseases. Coming to the second part of my lecture is, do we have a parameter which can assess the incorporation of iron into the developing RBCs? That is, in other words, any parameter which tells you about the hemoglobinization of the reticulocytes and what is the clinical utility of this parameter. And this parameter is reticulocyte hemoglobin equivalent and which we know as RET-HE. Now, what is it? We know the reticulocytes, they mature for 1 to 3 days within the bone marrow and then circulate for another 1 to 2 days in the peripheral blood before maturing into RBCs. Now, this parameter, it measures the hemoglobin content of these freshly produced reticulocytes. It gives you information on the supply of iron for erythropoiesis over the previous 3 to 4 days. In other words, it gives you the insight into the quality of erythropoiesis which is occurring, if the iron incorporation is optimal or suboptimal. This parameter is useful in differentiating between two common anemias, iron deficiency anemia and anemia of chronic disease or chronic inflammation. In iron deficiency, you have low ferritin and low retic hemoglobin equivalent, but in functional iron deficiency, ret hemoglobin is low, but ferritin is either normal or it is raised. Now, this slide shows how that ret hemoglobin, what is the distributed scatter plot of the reticulocytes and before iron therapy and after iron therapy. Now you can see there's an upward shift of the reticulocyte cluster. The RBC cluster has remained unchanged. So this is a very good parameter to see the effectiveness of intravenous iron supplementation in a patient who has iron deficiency anemia. So within few hours, you can have that there's a change as far as the reticulocyte scatter plot is concerned. Now, why it is so important as compared to the conventional parameters of erythropoiesis? Now, this gives you direct assessment of the iron which is actually used for the biosynthesis of hemoglobin. There is no other peripheral blood parameter which gives you this information. Now, we know the typical biochemical parameters of iron like ferritin and serum iron and TIBC. They are the indicators of iron supply, but they do not give you an idea what is the iron demand and whether the cells are actually using the iron for the synthesis of hemoglobin or not. So this is the parameter which gives you the actual real-time snapshot of how the hemoglobin is being developed in reticulocytes. Now, if you consider the conventional numerical parameter RBC indices like MCH, we know the lifespan of RBC is 120 days, and these parameters are affected very late, in the very late stage of iron deficiency. Therefore, in the current era of medicine practice, I think this ret hemoglobin equivalent is the earliest indicator of what is happening to the erythropoiesis, how much iron is being incorporated into the synthesis of hemoglobin of reticulocytes. Now, this parameter, unlike ferritin, is not affected by infection or inflammation. And that is the beauty of this parameter. Now, with the more accurate prediction of functional iron deficiency, this parameter is very useful in selecting the optimal therapy for patients who have chronic kidney disease, undergoing hemodialysis, or patients with heart failure. Now, when you treat these patients with erythropoietin with or without IV iron, if there's an increase in the reticulocyte hemoglobin equivalent, it indicates that effective therapy is effective. Now, this was a paper which was produced by Brugnera in 2006. More than 1,500 patients of CKD on maintenance dialysis. He studied iron deficiency anemia. And in this paper, what he has found out that with a cutoff of 27.2 picogram, this parameter is able to diagnose iron deficiency with a sensitivity of more than 93% and specificity of more than 83%. And this is one of the landmark paper in the initial period when the importance of red hemoglobin equivalent was being recognized by the hematologists. Now just focus on this graph. What you can see is this is the red hemoglobin equivalent in the iron deficiency. No, it is very less. Same is in thalassemia. Now, how to differentiate between the three? Most of the beta thalassemia patients have hemoglobin in the reference range, whereas in patients who have very low red hemoglobin equivalent, they would have microcytosis and hemoglobin would be low. And there are other conditions where reticulocyte could be low. One is the anemia of chronic disease. So the clinical utility of this parameter is directly measures the changes of iron incorporation within the erythropoiesis and able to diagnose very early stage of iron deficiency. In my last slide, in the last lecture, I had shown you how all the blood indices are normal. Only increase in the RDW-CV was the earliest indicator of iron deficiency state. Now we have another parameter that is red hemoglobin equivalent, which can identify the very early stage of iron deficiency when traditional biochemical parameters are non-informative. And I have already told you this parameter remains unaffected by inflammation, remain unaffected by uremia or infection, and therefore it is useful in certain conditions like patients with heart failure and chronic kidney disease. Now, since this parameter is a product of cellular volume and hemoglobin concentration, therefore it is falsely elevated in those patients who have dimorphic anemia, that is combination of iron deficiency or B12 or folic acid deficiency. Now, this parameter is reported as red He on Sysmex and CHR on Siemens. Both are interchangeable and equivalent parameters. And irrespective of the gender, its reference range is 28 to 30.8 picogram. So this was the first clinical study of red hemoglobin, which was published around 8 or 9 years back in JAPI, where we had performed bone marrow biopsy on 144 patients, and we had shown that this parameter is a good marker of bone marrow iron store in iron deficiency as compared to serum ferritin. And subsequently, an editorial was written by one of the best known hematologists of the country, Dr. M.B. Agarwal, and one of the best hematopathologists in the country, Swati Pai from Manipal, Bangalore. And they have written an editorial saying that now this is the new gold standard for diagnosing iron deficiency state. Now, if we compare the traditional biochemical parameters, now what are the day-to-day and week-to-week variation in test of anemia? Now, if you see the variation now, this variation with the red hemoglobin equivalent is 7.2%, but it's very high, nearly 41% with transferrin saturation and 22% with ferritin. And number of days which are required to determine the true average value, it is only 5 days with this parameter as compared to TSAT with the 226 days and ferritin 40 days with an accuracy of 95%. Now you can say how useful this parameter is in monitoring, in not only in the early diagnosis of iron deficiency anemia, also in monitoring the effectiveness of therapy. I think this I have already shown you this slide. So this was another pilot study we had done around 7-8 years back, which was published in JAPI. Now, as compared to the first parameter, I've told you that is the IRF, which we consider is the earliest marker of erythropoiesis. In this, we have shown that this reticulocyte hemoglobin is also one of the earliest marker of response to therapy in iron deficiency anemia, and both together can give you a complete picture of effective efficacy of the treatment. And this is a new trial. Of course, the trial we had, international trial we had completed. This is one of the largest trial on IV iron in pregnant women. The first article appeared in the American Journal of Obs and Gynae last month. And next month, we have another article which will be published in Lancet. And this one retic hemoglobin equivalent was one of the parameter which we had used to assess anemia in maternal as well as in the cord blood. So what are the contribution of these parameters in the diagnosis of anemia? I've told you that if you combine these all the 4 parameters, that so it gives you a combined information of quantity as well as the quality, and that gives you the total picture behind the anemia diagnosis. Reticulocyte percentage, reticulocyte number, and IRF, they quantify the mature and immature reticulocyte. They give you the quantitative assessment of anemia. And with this, you have a qualitative assessment of erythropoiesis. It gives you how much effective hemoglobinization of RBs or reticulocytes have occurred in the bone marrow. Now, coming to the third part of my lecture, what are reticulated platelets and what is the clinical application? We all know that patients with thrombocytopenia could be because of decreased production or increased destruction. Now, there are certain conditions which cause decreased production in the bone marrow, like aplastic anemia, leukemia, when you have decreased thrombopoietin production from the liver, or this could be because of viral suppression of the bone marrow. The common causes of increased destruction of platelets includes the most common is ITP, immune thrombocytopenia. Then you have conditions like TTP, or could be heparin-induced thrombocytopenia with thrombosis. So the parameter I'm talking about is immature platelet fraction, IPF. Now, reticulated, these are also known as reticulated platelets, and they are just newly released platelets, are just 1 or 2 days old and are just larger than the mature platelets. Now, till we had this parameter, there was no way that from the peripheral blood, we could assess what is happening to the megakaryopoiesis or thrombopoiesis. Now we have a peripheral blood parameter, which gives you what is the rate of production of the platelets in the bone marrow. And this parameter is same as what we have talked about, the IRF. It's basically analogous to the red cell precursor, that is reticulocyte. Now, since again IRF, it is a fraction, therefore it is the percentage of total platelets which are immature. And it measures the platelets which are newly released from the bone marrow. Now, what does it convey to us? Now, if you see the scatter plot of the platelet, what you see, the mature platelets, and this is the immature platelet, that is the immature platelet fraction. Now, if the platelets are low and IPF is low, it means there is a decreased production of platelets in the bone marrow. That is, the megakaryopoiesis or thrombopoiesis is less. If you have a patient whom the platelets are low but IPF high, it means it means there's a peripheral destruction. When IPF is high, it means the erythropoiesis, the thrombopoiesis or megakaryopoiesis is good at the bone marrow, and what is happening is the peripheral destruction of platelets, and therefore this is the picture. So using the platelet count and the IPF, you know what is the pathogenesis of the thrombocytopenia. Is it because of reduced production or is it because of increased destruction? Now, what is the clinical utility of this parameter? Now, I've told you this, it gives you an underlying pathogenesis of thrombocytopenia. You do not have to now perform bone marrow aspiration. Many times previously, few decades back, for all patients, almost it was mandatory for physicians and hematologists to perform bone marrow aspiration and biopsy in any patient who had chronic persistent thrombocytopenia. Now, but with this parameter, most of the times we avoid doing bone marrow. In fact, bone marrow aspiration in the evaluation of ITP is, I think, is almost has vanished from the clinical practice. Now, if you have an increased destruction, what I've told you, or consumption, it occurs in the ITP or TTP, and decreased production, I've told you, whenever the bone marrow is suppressed. Classically, the most common cause is aplastic. It can occur after chemotherapy, radiation, and so on. It not only helps in the pathogenesis of thrombocytopenia, it helps in monitoring the therapy in consumptive thrombocytopenia, like in acute ITP or TTP. When you're treating these patients, any increase in IPF during treatment, it shows that the thrombopoiesis is being upgraded, and we expect the platelets to rise in the peripheral blood. Now, often we use this parameter after radiation therapy or stem cell bone marrow transplantation. Now, it gives you early predictor of platelet recovery after chemotherapy, radiation, or bone marrow, I told you. And the most important thing is this IPF rise earlier than the rise in platelet count after bone marrow, and thus it tells you how it is a very sensitive index for the platelet recovery. And bone marrow, it is one of the earliest parameter to rise, which showed that after bone marrow transplantation, there is a recovery of the bone marrow, native bone marrow. And this was one of the papers, in 2006, initial paper, that this was a very good guide to platelet transfusion requirement after hematopoietic stem cell transplantation. They have shown that the first indication of recovery is the rise. If the rise has the potential to allow optimal transfusion of platelet concentrate. If a patient who has undergone hematopoietic stem cell transplantation and the IPF starts rising, it means that the thrombopoiesis is recovering, and then these are the patients who probably may not require prophylactic platelet transfusions. Now, after bone marrow, when the bone marrow recovers after the hematopoietic stem cell transplantation. So I told you this is one of the earliest parameter to in a recovering bone marrow. It takes 9.4 days as compared to IRF, which takes around 10. So these two parameters are very useful to assess the recovery of bone marrow after hematopoietic stem cell transplantation. Now just look at the the platelet scattergram, which I have shown you in my first slide on the CBC printout. Now, if this is a scatter plot which you see in a healthy individual, that is all you can see, there's a IPF immature platelets which are within the normal limit. Now, this is the patient who had, you see the large number of immature platelets, and it suggests that there is a destruction, peripheral destruction of the platelets. And this is the scatter plot of a patient of aplastic anemia, practically no immature platelets. That means there is a hypoproduction or almost no production of the platelets in the bone marrow. So just looking at the IPF number, looking at the platelet scattergram, you can make a diagnosis whether the patient has hyperdestruction or hypoproduction of platelets. So this was one of the earliest paper which came from Bombay, and you know Bombay that was one of the places where we had seen a lot of dengue patients in rainy seasons. And this was a paper which came from one of the hematologists, Kodaji. She is a well-respected name in the field of hematopathology. And the conclusion of this paper was that IPF is a good platelet recovery predictor in dengue patients. More than 84 patients showed recovery within 24 after attaining the peak IPF. More than 94 patients recovered within 24 to 48 hours of the rise of IPF compared with the previous day value. And 100 patients showed a recovery within 24 hours of the fall of IPF compared with the previous days. They also observed that nearly 94 patients, they show platelet recovery within 1 to 2 days if IPF was more than 10%. So the 10% is a magic number for IPF. So in any patients who have thrombocytopenia, irrespective of the cause, if the IPF rises and if you follow the kinetics of IPF daily, and if rises and keeps on rising and rises more than 10%, is a very assuring number to the clinicians and physicians. Now, I would like to all you to focus on this slide. Now, this is a slide, these are the kinetics of the platelet number and the IPF. The IPF, which is shown here in the dark rectangles, and the circle is the platelet count. This is a kinetics in a patient of 38-year-old male who had AML and had undergone chemotherapy and hematopoietic stem cell transplantation. Now, if you look here on day 3, the patient's platelet count, of course, was low. And since it was very low, around 20,000, so he was transfused 2 units of the platelet concentrates. What happened? The moment you give platelet concentrate to these patients, IPF falls to very low level. Now, these patients received platelet concentrates at regular intervals, and just see the IPF has remained depressed throughout the period. Now, at this point, around 21 days, the IPF rose to around this level at 12. But since the platelet count was very low again, and of course, this patient was not bleeding, but was given a prophylactic platelet transfusion. What happened? Again, IPF came down low, and it remained low even when the platelet count has recovered. The message I really want to give is that IPF precedes increase in platelets, and prophylactic platelet transfusion may decrease the IPF and delay the platelet recovery. This is being illustrated in this paper. So if patient is not bleeding, has low platelets, but is not bleeding, then one should not give prophylactic platelet transfusion, because the moment you give transfusion platelet, what will happen? IPF will fall, and IPF is a marker of platelet recovery. If IPF falls, the recovery of thrombopoiesis will be delayed, and therefore giving unnecessary platelet transfusion, you're doing more harm to the patient than doing good. Of course, the exception is when the patient, even at low platelet, is bleeding. Of course, then you have to give, since it is a life-saving management, therefore you have to give platelet. Otherwise, if patient is not bleeding, even has platelet count around 8%, 8,000, 10,000, and is stable, there's no need to or panic to give prophylactic platelet transfusion. Just observe the kinetics of IPF daily along with platelet count, and you will become wiser, what I have already listed in my last slide. So to summarize the how do you use this parameter as far as the transfusion assessment in patients who have thrombocytopenia? If you have low platelet and low IPF, it means no production, and therefore these patients may require platelet transfusion. But if a patient has low platelet but high IPF, if it is more than 10, that means production is good, and you should not transfuse unless and until the patient is bleeding. And that bleeding should be a major bleeding, not a superficial or minor bleeding. Now, coming to the fourth advanced hematological parameter is the immature granulocyte, that is IG. In the printout, I showed you that it is available both in percentage as well as in the number, that is the quantitative number. Now, these are the immature granulocytes, the metamyelocytes, myelocytes, and the promyelocytes. Now, we have all during our PG course and learning, we have seen that there's always, whenever you have seen the peripheral smear report, always many times in a patient who had inflammation or infection, there was a mention of left shift. Now, this left shift was being utilized by physicians and internists for decades. Now, this definition of left shift has a lot of variety of definitions. What do you mean by it? Is it the presence of band neutrophils or the presence of band metamyelocytes or myelocytes or promyelocytes? Now, when we used to measure the pathologists, when they used to give the report of band forms, that is the band neutrophils, they used to count 100 WBCs and do a differential, and they would give a report. So just counting only 100 cells and you give a report was totally inaccurate in the current era of technology, where we use more diagnostic parameters are more accurate now and more advanced. So now with the cell counters, you are able to measure the immature granulocyte, that is the metamyelocytes, the myelocytes, and promyelocytes. And the cell counters, they count over 32,000 cells and generate this parameter as compared to only 100 cells, WBCs, which were counted by the hematopathologist. Now, you can not counting of the 100 WBC was time consuming also, and it reproducibility was more difficult. But with cell counters, you can generate a very accurate level of immature granulocytes. It is reproducible and you can have it within few seconds. So it is only part of the cell counter machine. Ultimately, it comes up with all other CBC results. And therefore, except for that, you have to just have to add a software to your cell counter, and within few seconds or a minute or so, you have the whole a picture of the granulocyte, that is the immature granulocyte, both in terms of percentage as well as the number. So if you look at the wide differential channel flow cytometry, this is the immature granulocyte. What you see is the neutrophils and the basophils. These are the monocytes, and these are the lymphocytes and the eosinophils. So you have a scatter plot like this. When you have good number of immature granulocyte, that means you are dealing with a patient who has infection or inflammation. Now, what is the clinical utility of this parameter, that is immature granulocyte? It is more sensitive and specific for infection than WBC, and is almost comparable to the absolute neutrophil count. Now, if Ig is more than 3%, it predicts a positive blood culture up to the tune of 92% specificity. Of course, it is understood that the blood culture is drawn, the blood is drawn for culture before any antibiotic is infused to the patient. Now, this parameter, it improves the predictive value of infection by adding this parameter into the other laboratory tests. Commonly, what we do is the procalcitonin, or we ask the pathologist to look for the cytoplasmic granules or the Dole bodies on the peripheral smear. And therefore, this is a very early potential, can identify acute early infection or inflammatory response at a very early stage when all other parameters of sepsis or inflammation are within the normal range or they are non-specific in that clinical situation. So to sum up, the immature granulocytes, that is the immature granulocyte, it more than 3% indicates that significant left shift is present. 1% indicates only a left shift. And now it is part of the investigative procedure for the diagnosis of sepsis or inflammation. I told you IPF is very important. It suggests what is happening to the thrombopoietic activity in the bone marrow. Whether when IPF is low, it means there is a underproduction. IPF is high, that is means there is a hyperdestruction of platelets in the peripheral blood. Reticulocyte hemoglobin equivalent is not only the earliest marker of iron deficiency anemia, it also is one of the earliest marker of effectiveness to intravenous therapy, just like IRF. Both are almost comparable to each other, though in our study we had shown that this red hemoglobin equivalent is slightly a better early marker of erythropoiesis as compared to IRF in iron deficiency anemia. So to conclude, these newer parameters, which are advanced parameters, which are available now almost on most of the sophisticated cell counters, which are available in medical college hospitals or corporate hospitals or hospitals located in major cities, they help us to guide early and provisional diagnosis with minimum test of CBC or peripheral smear. They help in monitoring the effectiveness of therapy. And the last time also I have requested all the residents, especially and all physicians and clinicians, please ask your pathologist to provide you a complete printout and not the typed report, because the typist would just include few of the numerical parameters, and the wealth of information which is available in the CBC printout will be missed. And so always request a complete printout from the lab, and learn to identify whatever I have discussed in last Tuesday and this Tuesday. You should please go through your CBC printout, and you will find out that this piece of paper is a wonderful piece of paper to make a diagnosis at bedside in a few minutes. Thank you very much. If there are any questions, I will most welcome. Yes, Dr. Maheshwari. I think some of the attendees are having a good sleep. So my talk was much better than the normal sedative which you take at night, alprazolam or zolpidem and so on. Yes, Dr. Yuvraj Singh, you have please unmute yourself and you can ask. I think all are muted. I think please unmute yourself if there are any queries, any questions you want to address to me. Yeah, Dr. Shamal Das, I think you'll have to unmute yourself.
Yeah.
Dr. Maheshwari, I think is not there.
Yep. Dr. Mehta?
Yes.
Yeah, Dr. B.K. Gupta here.
Yeah, yes, B. Gupta, how are you?
Yeah, fine. Thank you. Thank you very much. Excellent presentation. Excellent insight, deep insight, I rather say, that to interpret these advanced parameters for clinical setting and so as to avoid unnecessary bone marrow aspiration, bone marrow biopsy, and unnecessary platelet transfusion. Excellent, sir.
Thank you, Dr. BK.
I think every student must जैसे कहते हैं ना घोट लेना चाहिए उन लोगों को इस सारी लेक्चर को जिससे कि दे मस्ट हैव मैनेजमेंट एट प्रॉपर्ली and at within time, especially we are facing a lot of dengue cases, and many of the dengue cases they are given platelet transfusion unnecessarily. So your lecture will teach us all the
Yeah, you are right, actually. Now we are just, there's another study is being underway now. Now we are showing that reading CBC printout at the bedside will take few minutes to make a diagnosis. And we want to compare how accurate we are and what is the final diagnosis of the patient. So initial diagnosis at bedside when the patients come to us, and what is the final diagnosis, we want to see how much there's a coordinates or discordance between the two. And this paper, I think, will be published in the next few months' time. Once we complete, it is in the underway, and probably this is the only, probably to the best of my knowledge, is the only study in the world where it has shown that making a diagnosis, a bedside diagnosis from CBC printout, and what is the final diagnosis at the time of discharge of the patient. So the rate of concordance or discordance between the two, agreement or disagreement. So I think we are, another 2 or 3 months time, we'll have this paper published in a good journal.
excellent. Excellent, sir.
Dr. Mehta, I am Dr. Sanjay Kumar here.
Yes.
Yeah, very nice lecture, sir, regarding the ABG. And definitely a lot of decisions can be made if you read the ABG properly. One thing just I want to know that sometimes there is a big discrepancy between the manual platelet count and the platelet count by ABG machine.
CBC machine, CBC. Yeah. So now.
Sorry, in CBC. Sorry, in CBC.
Most of the machines which are of low cost, basically, they work on impedance mechanism, impedance method. And when the platelets are less than 50,000, that is, there is marked thrombocytopenia, then impedance is quite inaccurate. So what you require is the flow cytometry, the enumeration of the platelet by flow cytometry. So most of the sophisticated cell counters, of course, they are available in almost all the cities, big cities, hospitals. They have the inbuilt flow cytometry mechanism to assess the platelet count. Now, if the platelet count is low by impedance, you get it checked by the what you call the flow cytometry. And I would add to this, CBC is only one side of one face of the coin. The other face is the peripheral smear. They ask the pathologist to examine the peripheral smear. At times, because in one of the lectures I'll take later on, I'll talk what are the pre-analytical and analytical errors in platelet counting. Now, platelet count is a very, to have a proper sample, it is very important to have a proper sample and how to interpret that sample also. So,
Yeah.
so with peripheral smear, you can cross-check the number which is generated by the cell counter, provided even if you have large or very large platelets or giant platelets. I've told you last time that it would be counted in the RBC counter. So there would be possibly low platelet count. Now, the same you can recognize on the peripheral smear, and then you can, yes, so many times the platelet count is 1 lakh on the cell counter, and the pathologist reports on peripheral smear adequate, that is 1.5 lakhs. So this is, and of course, the platelet count by flow cytometry is the most accurate method.
Thank you, sir. Thank you, sir. And you have highlighted the sampling for the platelet is also very important. How the sample is being collected.
Yeah.
So so I remember it was the classical teaching at our time that platelets are very fragile and it should be the blood should be taken very swiftly. Otherwise, the
Yes.
platelets may break during the collection system also.
In the course of this course program, I'll take one class on what are the fallacies in platelet counting.
Okay, so nice, sir. Thank you, sir. Thank you.
Thank you.
One thing I would like to ask, if you take sample from by vacuum sampling, that is some they are doing by vacuum sampling.
That is, yes, it does not affect.
Okay.
Actually, the draw of blood should be very clean in a single try.
Mm-hmm.
And the moment you put it in the vial, you should not shake it. You just have to tilt it 8 to 10 times only.
Mm-hmm.
Yeah.
Okay. Thank you.
Sir, there is a question by Dr. Neha Kumari that
Yes.
in CKD, low reticulocyte count is due to decreased erythropoietin or bone marrow problem. How to differentiate it?
Low reticulocyte count.
Yeah.
She's talking about red hemoglobin equivalent. Can you repeat the question, please? Just repeat the question.
The question is in the chat box.
I'll just see. There are 33 messages are there by
Last message, sir. Last message.
okay, last message. Okay. In CKD, how to differentiate whether low reticulocyte count is due to decreased erythropoietin or bone marrow problem? No, I think basically what she means is, see, erythropoiesis, which is the stimulator of erythropoiesis is the erythropoietin. Okay. Now, in CKD patients, it is well established the erythropoietin is decreased, and therefore, subsequently, the bone marrow is normal. It is simply that it does not have a stimulator. The ingredients are there, but because there is lack of erythropoietin, and therefore the erythropoiesis is underproduced. But at the same time, in CKD, it is a state of chronic inflammation, and chronic disease. So you have high level of hepcidin. Now, hepcidin also impairs the incorporation of iron into the RBCs, reticulocytes. So it all depends whether ferritin is normal or low and red hemoglobin is low. You can differentiate that is there's a true iron deficiency in these patients or there's a functional iron deficiency. I think I'm able to clear her query.
Yeah, yes, sir. Yes, sir. Yes, sir. Yes, sir. Yes. Since there is no more question, we may end here. On behalf of Dean ICP Dr. Kamlesh Tiwari, I, as a Joint Secretary, I would like to thank Dr. Mehta and all the participants for joining this class. And really, it was a wonderful learning, not only for the students, but for us also. So we hope that we will learn more and more as the classes will progress. Thank you, sir. Thank you again. Thank you to
Dr.
all the
Sanjay.
participants.
Thank
Thank
you.
you.
Thank you, Sanjay.